I'm Dr. Michael Cheezum, Chair of the Fellow and Resident Leaders of the Society of Cardiovascular CT Committee, and I'm joined by Dr. Jeffrey Carr, the Cornelius Vanderbilt Professor of Medicine and the outgoing SCCT President. And thanks for your time.
Michael, yeah, it's really great to be here at beautiful San Diego. SCCT 2014 has been a tremendous success. This past year, we have done a phenomenal amount of activity. SCCT is a global organization, and this past year, we've really reached out by expanding the international regional committees. We had a dedicated session with China this year, where we learned amazingly that they did 2.4 million cardiac CTs last year as one country. It's just phenomenal explosion of cardiac CT in Asia, and SCCT is part of that through our international regional committees. We also had a very successful winter meeting in Hawaii that was 50% of participants from the Asian Pacific Basin. So SCCT is really growing, and San Diego has been really exciting. Now, that's not even talking about all the great science. The science this year has been phenomenal. We're getting ready to do our review of the scientific sessions, whether it's fractional flow reserve with CT, CT perfusion, or new technology. All the vendors are introducing unbelievable new capacity, scanning at speeds unheard of or unpredicted even just 10 years ago. So the future of cardiac CT and coronary CT angiography is really unbelievable.
Sounds like you've had a busy year as the president, and there's lots to look forward to with the next year and heading to Vegas for SCCT 2015. At this meeting, is there anything that struck you in terms of data presented or things to look forward to?
Yeah, well, we'll be in Las Vegas next year. We also have our Hawaii meeting again in January. But really kind of the game-changing technologies and clinical applications, I think, are transaortic valve implants. I think we're seeing that in clinical practice, both in North America and in Europe. There's a tremendous uptake of minimally invasive aortic valve implants, and I think that's really just the beginning. That's the importance of CT in both preoperative planning and selecting implants is something that we spend a lot of time really training people to be at the very cutting edge to optimize patient outcomes. And that's a real role that cardiac CT can do. So, using cardiac CT, we can help select the right patient, right implant, and right answer. The other really emerging activity, CT in the emergency department, the management of acute chest pain in a very efficient and patient-friendly way. And then perhaps most importantly is the tremendous reduction in radiation exposure. I think there were at least 8 sessions where we looked at routinely getting CT scans of the coronary arteries for under 1 millisievert, comparable to a mammogram. Truly amazing. This is not just in lean people with new low kV imaging, imaging at 70 kV, dual energy. We're really pushing the envelope by coupling it with iterative reconstruction to get high quality images at very low radiation exposure to our patients.
Yeah, it's great to see the CT community, overcome some of the limitations in CT and those 50% dose reductions every 2 years, 2005 to 2010. Just one front there. What remains a limitation to cardiac CT in terms of reimbursement, and how do we overcome that?
Reimbursement is challenging. We're all under cost constraints. One of the things that we've done for advocacy is we've had really significant gains through our communications with payers. Just this past month, Humana has dramatically broadened its coverage of coronary CT angiography indications. We're working with local carriers in all of the regions of the United States. And I think importantly, we're sharing lessons learned. So you take the UK National Health Service, their embracement of cardiac CT and their experience with cardiac CT is very similar to some of the larger payers in that we're seeing cardiac CT has such a long warranty period that we're seeing patients managed more effectively at lower costs with better outcomes. So I think the future is bright. We're starting to have the years and thousands of people of evidence that I think is really going to start to sway both private payers and government payers of the value of cardiac CT in appropriate patients.
Dr. Carr, thanks so much for your time today. Thank you for the opportunity for the First Committee to be a part of the society. And we look forward to seeing you at SCCT Hawaii and SCCT Las Vegas.